Hi, my name is Dr. Ian Katz, and this is an introduction to basal cell carcinoma, or BCC, for primary care doctors. I thought I'd just review the normal skin. In the normal skin, there's the epidermis, which is the superficial layer, there's the dermis, which is the mid layer, and there's the subcutaneous tissue, which is the deeper layer. Within the epidermis, the basal cells are the cells which occupy the very deepest part of the epidermis, and this is where it's thought that the basal cell carcinomas arise. So skin cancers, there's lots of different types, and they can be primary or metastatic to the skin and can be derived from any of the structures of the skin. From the epithelium or epidermis, you can get basal cells and squamous cell carcinoma. From the melanocytes, you can obviously get melanomas, and then you can also get tumors rising from blood vessels, from adnexal structures, or any other parts of the skin. There's three main types of skin cancer: the basal cell carcinoma, or BCC, the squamous cell carcinoma, or SCC, or melanoma. And the first two are often called non-melanoma skin cancer. BCC is the most common type of skin cancer. In fact, it's the most common type of cancer of any type of cancer, and it's related to sun exposure. Thus, it's more common on sun-exposed areas. There are also rare syndromes that can have increased risk of basal cell carcinoma, such as the basal cell nevoid syndrome or Gorlins syndrome. With BCCs, if you've had one, you have 50% risk of having another within 3 years. Most BCCs are just locally growing and grow quite slowly, but they can be locally destructive if left alone for extended periods. In the olden days, they used to be called rodent ulcers because after they'd been left a long time, they were bleeding and eroded and looked just like a sore, as if a rat had taken a bite out the patient. Very rarely do basal cell carcinomas metastasize. So we like to divide basal cell carcinoma up into low risk and high risk subtypes. So the low risk subtypes are multifocal, superficial, and nodular, and the high risk subtypes are micronodular and what we like to call morphic or morphiiform, which includes morphic, sclerosing, and desmoplastic subtypes. There's also metatypical or squamous subtypes. The problem with subtype in basal cell carcinoma is there actually is no real definition of the various subtypes, and there is a huge variability between pathologists in distinguishing the various subtypes. The other problem is that they're often quite mixed subtypes, but there's no literature on when to report the presence of a particular subtype, e.g. if there's a predominantly nodular basal cell carcinoma with a small amount of morphic basal cell carcinoma, should one report it if it's less than 10%. The other problem is that often one gets scarring and morphic-like changes after biopsy. So there is no real definition of the various subtypes of basal cell carcinoma. Often the subtype on a small biopsy may not be found in the wide excision or the curette, and additionally there may also be squamous differentiation in a basal cell carcinoma after biopsy, and the wide excision may look exactly like a squamous cell carcinoma. So this is a biopsy of a very small fragment of a basal cell carcinoma. It's actually really difficult to be sure what the subtype is. So with low-risk basal cell carcinomas, as I've said, that's multifocal, superficial, and nodular. Recurrent lesions can actually come back as high-risk subtypes. But generally, we do not need a wide margin, and you can even use topical therapy, even curettage and diathermy for many of these lesions, even on the face in older people. With nodular BCCs, it's the most common type of BCC on the face, and it usually presents as a small, shiny, skin-colored or pinkish lump. It may have a central ulcer so its edges appear rolled. It's a classic rolled edge appearance and can often bleed spontaneously and seem to heal over. Cystic BCC may be soft with jelly-like contents, and a rodent ulcer is an ulcerated, long-standing nodular BCC. If it's a more micronodular and microcystic, they may infiltrate quite deeply. So this is what a nodular basal cell carcinoma looks like on histology. It's a nodule of BCC in a small biopsy. On dermoscopy, there's usually anastomosing blood vessels across the surface, and there may be some pigment. So this is a dermoscopy picture of a nodular BCC, and you can see on the surface how you get these anastomosing blood vessels. This is quite typical. There's a small area of ulceration with scaling in the center. There's some pigment, maybe just part of the normal background pigment. Again, anastomosing vessels on top of a small nodule. Sometimes you can get pigment within a basal cell carcinoma, and this is often described as these blue-grey clods, and you often get something called maple leaf structures. pigmentation in nodular basal cell carcinomas is actually quite common. Again, another pigmented BCC. Again, another pigmented BCC. Again, you can see some vessels and some pigment in this one. A pigmented BCC. Another pigmented BCC. So high-risk BCCs, it's the morphic sclerosing desmoplastic BCCs. So we often lump them together under morphic BCCs. Also, there's micronodular BCCs and the metatypical squamous differentiation in BCCs. Now, with these high-risk BCCs, we more often need formal excision with wider margins. Perineal invasion is more common with high-risk subtypes or recurrent BCCs, and generally we try to report in the lab the rough size of the nerve and where the tumor is located. In other words, whether it's within the main tumor bulk or away from the main tumor bulk. And this is important if a radiotherapy consult is required, because a perineal invasion of a small nerve within the main tumor bulk is probably not that significant if it's well away from the margins. So again, here's a couple of pictures of perineal invasion. You can see the nerves here with lots of basal cell carcinoma. These are the basaloid cells around the nerves. Treating BCCs is generally quite easy as long as they're caught early, and there are very many different options depending on the many different patient and doctor factors. That's a topic for another talk. Thanks for listening.